Good evening, everyone, and welcome. My name is Warren Hall, and I'm the National Manager of Support Services for the American Liver Foundation. ALF was founded over 45 years ago and is the nation's largest patient advocacy organization for individuals with liver disease. Each year, we engage over 5 million people through our robust education, support, and awareness initiatives. As part of our commitment to the liver community, ALF offers a range of educational programs for medical professionals as well. This program this evening is being delivered on the Zoom webinar platform, and it will be recorded. During this presentation, if you have a question or comment, please hover your mouse over the bottom of your screen and click on the chat feature. We'll make every effort to ask all the questions during the Q&A portion of this evening. Again, please note that this program is being recorded and will be available on ALF's YouTube channel for future viewing. We ask that you please be sure that your microphone is on mute so as not interrupt the presentations. We're very excited to work with Integra Life Sciences to raise awareness among transplant surgeons, fellows, and other providers about innovations that are helping to improve transplant patients' experiences and survival rates. Now we'll have a brief word from Integra.
CUSA Clarity Ultrasonic Tissue Ablation System, powered by Tough Tissue Technology. CUSA Clarity, designed to maximize surgical performance. Powerful and precise. Easy to set up, so it's ready when you are. Intuitive. Precision handpiece, designed for safety and comfort. Experience the next generation ultrasonic tissue ablation system, powered by Tough Tissue Technology. CUSA Clarity. Power, precision, performance.
Once again, we thank our sponsor for this evening's program. Now, this presentation tonight aims to update transplant surgeons, interventional radiologists, fellows, and other medical providers on the latest innovations in liver resection and tumor removal. Topics that will be touched upon include some patient selection, surgical techniques, prognosis, and more. The format decided upon for this program will be based on case studies, followed by a Q&A where we invite our viewers to put your questions into that chat feature, as mentioned earlier, so that they can be addressed by our presenters. Now, that's a nice segue, I think, introducing our presenters for this evening's program. They're first Dr. Talia Baker and Dr. Roberto Hernandez Alejandro. First, Dr. Baker is an internationally renowned expert and leader with more than 20 years of outstanding achievements in the field of transplantation. She joins us from the University of Utah, where she serves as the chief of the Division of Transplantation and Advanced Hepatobiliary Surgery. Dr. Baker brings extensive leadership experience as division chief, works collaboratively with the Surgical Transplant Service line team and affiliates, including transplant services at Primary Children's Hospital and Intermountain Medical Center and Hepatobiliary Oncology at Huntsman Cancer Institute and Hospital. Dr. Baker came from the University of Chicago, where she served as professor of surgery, director of transplant oncology, and director of living donor liver transplantation, and as surgical director of liver transplantation. She completed her general surgical residency at New York Presbyterian Medical Center, followed by her multi-organ transplant fellowship training at Northwestern University Feinberg School of Medicine, where she remained until that appointment to the University of Chicago. Dr. Roberto Hernandez Alejandro is a liver surgeon and has been the chief of the Division of Transplantation at the University of Rochester and professor of surgery since August of 2016. He was formerly the director of liver transplantation at Western University in Canada. He completed a transplant and hepatobiliary surgery fellowship from 2000 to 2006 to 2008 at Western University in Canada. Subsequently, he received further training in live donor liver transplantation at the Kyoto University in Japan in 2009. He's been a champion of organ donation throughout his career. Dr. Hernandez was a pioneer in utilizing donation after cardiac death organs to increase the number of livers available for transplantation. Under his leadership, URMC successfully restarted their live donor liver transplant program, performing over 40 operations in 4 years. He has demonstrated his ability to grow a program by leading his team to double the number of organ transplantations in just 4 years, with the best survival rates in 20 years. He's recruited and mentored a diverse team of academically and clinically successful physicians and surgeons since being appointed chief at URMC. He has also dedicated a significant portion of his career to mentoring academically successful hepatobiliary and transplant surgeons around the world. Dr. Hernandez Alejandro has more than 100 peer-reviewed publications in the area of liver transplantation and is a committee member of many international societies. Now, I want you all to know that I surgically edited down those bios, which just indicates to us how accomplished both of our presenters are this evening. And so it's a great honor to invite them now to begin our program, and I'll begin with Dr. Baker.
Thank you, Warren, for that beautiful introduction. But I know I can speak for Roberto, Dr. Hernandez. We are both really grateful to be here to present to you this new area of liver transplant, which both of us feel really passionately about. I wanted to start by giving just a brief introduction to what is liver transplant oncology. So liver transplant oncology, first I want to say I have no relevant disclosures, except to say that I am significantly disturbed by the increased projected cancer mortality rates in the liver, which are being demonstrated worldwide. I think this really moves us all towards this area where I think we can really make great progress. So what is transplant oncology? Transplant oncology is at its base, it defines an application of transplant medicine and surgery, which is aimed at improving cancer patients' survival and quality of life. In practice, these principles really apply most relevantly to liver transplant, which is the only solid organ with demonstrated efficacy in curing liver cancer by removing not only the cancerous lesion, but also the underlying cancer-promoting environment. What is liver transplant oncology then? Liver transplant has contributed to the cure by extending the conventional margins of surgical oncology and what they can accomplish and eliminating the concurrent cancer progressing favor conditions that are found in a scarred liver. Resectability of liver cancer conditions is not an exclusive technical argument. There are often things which we know are technically resectable, but we have to understand the biology-driven adverse prediction of recurrence in cases of these technically resectable tumors, which should lead us to at least consider transplant considerations as first options. The successful strategy of liver transplant for cancer depends on reliable determination of the liver-exclusive tumor location and growth. It requires that we avoid transplantation when extrahepatic cancer deposits are presumed beyond what we can make the surgical bed of a total hepatectomy. So liver transplant efficacy is certainly increased in tumors with objective and sustained response to neoadjuvant bridging or downstaging therapy, as both Dr. Hernandez and I will describe to you in the separate cases of metastatic colorectal mets, as well as intrahepatic cholangiocarcinoma. So liver transplant oncology at its core, it's really a precarious balancing act between immune regulation for graft tolerance and cancer recurrence. It requires a multidisciplinary assessment of the pre-transplant tumor biology, which is really the major determinant of prognosis. And in addition, minimization of immunosuppression post-liver transplant and consideration of adjuvant therapy is certainly essential and something that we as transplant surgeons have not been used to doing in the past. So in transplanting patients with cancer, minimal inclusion and exclusion criteria, as you will hear today, and achievable endpoints really need to be defined a priori. And I think this is one of the major things that we're working on currently. And transplant appropriateness should really be pursued, balancing individual versus community practice. Certainly, issues of organ allocation have to be fair, efficient, utilitarian, applying urgency, utility, and transplant benefit criteria, as we've always done, but really in a new arena now. We have to consider now tumor burden, certainly tumor biology. We have to consider where we are in the country and consider waiting time versus the efficacy of living donation and the ethics around that. And certainly we have to understand and respect response to tumor treatment. So with that, I'd really like to turn the table over to Dr. Hernandez, who will tell us more about metastatic colorectal disease. And I think all of these principles will be applied in a way that will make this all really come home to you. So thank you to the ALF and to Warren for putting this really important seminar together. And with that, I'd love to let Dr. Hernandez give his part of the presentation.
Perfect, thank you. Thank you very much. Just want to be sure that I can share my slide. Can you see my slide?
Yes.
Oh, sorry for that. Are we okay? All right. Well, thank you very much, Talia, for this great introduction, and I appreciate and thank you very much for the introduction and the invitation from the American Liver Foundation. This is a great honor for me to be presenting on this such an interesting topic that is growing and getting a lot of attention in the United States and in many other countries, and I think it's the power of liver transplantation in an area that we have been pushing since many years ago of oncology. We have done this for many years, since the 90s in HCC, and I think with a lot of the advances that have happened in the area of oncology and transplantation, it's why we can do more things in other type of cancers. And this is in metastatic disease of colon cancer. I have nothing to disclose in relation to this presentation. Reviewing and the colorectal cancer, this is quite impressive to see in the United States, more than 150,000 new cases in the last year. And we know that around half of them will develop liver metastases, whether this is at the moment of diagnosis or within the next 3 years, despite treatments. And we know that the only curative treatment is surgery. Not all the patients are going to get cured, but majority of who are operated and they have a good operation, they will do well when we do liver surgery and primary tumor resection. And this graph is showing us how the incidence of colon cancer has been decreasing in these ages, in these decades, in the 50s and 80s, because we're doing more screening colonoscopy and the country is doing a good job there. The problem is this, other 20s, it's impressive to see this nowadays, 30s, 40s, and late 40s, which we didn't see that before. And in this paper also, we were able to see impressively, this is the highest growing population in the 20s and 30s that is increasing. And we don't do screening colonoscopies in these patients. And many of them, they don't have a history of family history of cancer. So this is quite impressive. And a lot of them, when they are diagnosed, they have pretty advanced disease. We know, and we mentioned that the best treatment will be resection, but only around 20% of these patients, depending on the literature and depending if we could be aggressive, but around 25% of the patient would be resectable. And of course, the concept of resectability can be technical, oncological. It depends also on the number of metastases, location of them, and also the experience of the centers and the surgeons who are involved in this treatment. What happened with the patients who have not resectable disease, and the patients receive chemotherapy that we know nowadays, since around 12, 15 years ago, we have a very good success rate of response to chemotherapy with FOLFOX, with FOLFIRI. And we can see that these patients, if they are unresectable, they will have a survival around 5 to 10% at 5 years. And this is why we do surgery when we can do it, because survival is much better when we compare to that. This is at 10 years, could be as 30%, and perhaps around 40% at 5 years survival of the patients who are resected. We have developed complex hepatectomies, the two-stage hepatectomies for some patients that when it's difficult to operate them because of small liver remnant, and all of you know that portal vein embolization is a way of increasing the left lateral segment of the liver or the entire left side of the liver. Or we can do a two-stage hepatectomy where we resect and clean the left lateral side of the liver, then we ligate or embolize the right portal vein. And in just a few weeks, we're going to have an increase of the left side of the liver, because the portalized liver is going to be working as an auxiliary liver. And then in a second stage operation, around 6 to 8 weeks, we will go and remove the right side. And the patient is supposed to be free of disease. The problem is that not all the patients do well here. There's a high morbidity in the second stage, close to 50%. We know that the median number of tumors in this study of 5 number, like very top centers, they have not the best outcomes, but overall they have a survival acceptable. But we know that the disease-free survival of these patients is between 20 to 25% at 3 years, and these are data coming from Andy Anderson, data coming from Paul Bruce. This is another procedure which I was involved when it came to America, and I have the opportunity of being pioneer on this in Canada. And this is the ALPS procedure, which is very similar, and we divide the portal vein and we do a transection. The way that I personally do it is a complete transection all the way to the IVC. We believe that the trauma that we generate in the liver will create accelerated hypertrophy, and in just 7 to 10 days, we're gonna sometimes even double the size of the future liver remnant, and we can go and remove the deportalized liver. And it works, and this is an example. This patient has a pretty small left lateral segment, and actually part of the segment 4 with this metastasis. And this patient has this hypertrophy that is quite impressive. The patient did very well. They had recurrence after around 3.5 years, which was ablated. What is the outcome of all these patients? All these patients will have recurrence, majority of them. And the survival is going to be perhaps around 30% at 5 years, or even lower, depending on the series that we treat. So overall, these patients where we do major resections in heavily pretreated have major complications in this study. Major resections, 40% major complications, 10% mortality. 40% of the patients who have more than 12 cycles of chemotherapy, they have 55% of major complications, 20% of mortality, and all of them have recurrence at 3 years. So I think this is telling us that we need to be cautious with these type of patients when they are heavily treated and with high tumor disease. And this is what we see sometimes in clinic, and this is quite impressive to see these patients that come in a very young age. And this is what the new options of liver transplantations come. And this comes from the group from Norway, when they have a special situation when they have a very short waiting list in Norway. If you are listed for liver transplantation, you get a transplant between 30 to 45 days, right? We don't see that in this country at all. But those patients, they start using some of their organs in patients with colorectal metastases. and who were unresectable with no evidence of extrahepatic disease, and they were responding to chemotherapy just for 6 weeks. And this is what they were able to show: an impressive survival at 5 years of 60%. And unfortunately, all the patients have recurrence. A lot of the recurrence was in the lungs, but not there. But this opened the Pandora's box, and people start exploring what we can do. The Norway group did a very detailed analysis in their patients, and they created this score. And these were the tumor size, the level of the CEA at the moment of transplant, if the patient was progressing or not on chemotherapy, and the time interval between the diagnosis and the transplant, and they created this score. If we have 0, the best outcome. If we have 4, the worst outcome. And it's represented in this graph, which patients who have a score of 0 to 1, they have a survival of 100% at 5 years. We have to be cautious because this is a population of 16 patients. So we have to be careful with this. Now, they went even a little bit more far away with their criteria, and they start doing something that they call the MTV score, the metabolic tumor volume. And there's a formula which is we can see in this manuscript, where they calculate the ability of the tumor, and if it's less than 70 cubic centimeters, then the outcome is going to be much better when compared to those ones who it's above 70 cubic centimeters. Nowadays in Norway, they use this as a criteria for selection. In my experience, we are checking on this. We're doing this. We start doing a retrospective study. Now we're doing prospectively, and it's a tool that helps us for taking decisions for the future patients. Interestingly, the patients who have recurrence after liver transplantation, the vast majority of them is in lungs, not necessarily in liver. But the association of what organ is affected is what is going to determine the survival. Pulmonary recurrence doesn't necessarily affect the outcome of the patient and the survival, while when there is hepatic recurrence, the outcomes are very bad. And this is a paper that was just, and sorry for this, that it says here accepted, because it's not already, it's just ahead of print published. And this is 10 years follow-up of 23 patients in Oslo. So, and this is showing us those patients who have an Oslo score of 0 to 1 at 10 years have 50% survival. Oslo score of 2, close to 40%. So this is pretty impressive, because a lot of our colleagues on surgical oncology, they say we need to have data for 10 years. So I think this is an impressive result that they are sharing with us. What is happening in the United States? We published with the group from Cleveland Clinic Foundation in Ohio and the group from Toronto. We published this paper in JAMA Surgery. I think it was in April of this year, where we presented the first 10 cases in the United States using living donor liver transplantation. And you can see a very acceptable overall survival of these patients, and the recurrence-free survival is represented here. So not bad start in the United States, and I think we're validating in some way the Norwegian data. This is what is happening. In this map represented the center so far, probably around, I think, 2 months ago, when I did this slide, that are doing liver transplantation. And the ones who are here bigger are those ones who have done more than 5 cases in Methodist, in WashU, Cleveland, Pittsburgh, and Rochester, New York. Dr. Sasaki, who is in Stanford currently, did this study trying to publish this. It's just the activity that is happening at UNOS. And these are the patients who are transplanted and listed for liver transplant for colorectal metastases. And I would expect this one is going to go higher in 2022. And this is some of the outcomes, which are pretty impressive. But what is more interesting is to see that some of the organs that were used were deceased donors, not necessarily living donors. Why they were able to transplant with deceased donors? Well, perhaps that this was during the moment where some centers have more capacity of getting some extended criteria organs, and they were able to use it in these patients. And some patients have a very advanced liver disease because of the multiple treatments that they get, such as SBRT, not only chemotherapy, Y90, or the hepatic artery pump infusion. In Norway, the patients are chemotherapy only. So I think we have a different population of patients here, very different than Norway. And those patients who receive deceased donors are those patients who have more liver disease. So the parenchyma is more affected and some liver dysfunction. In Rochester, we put our protocol. We follow the Oslo criteria. We try to go below 2 of Oslo criteria. However, reviewing our data of our patients retrospectively, we have only done patients with Oslo score 0 to 1. And we also added here more to, we try to be cautious because we're doing this with live donors. And then I think we have to guarantee. For us, a patient who has a CEA more than 80, or someone who is progressing is a contraindication. So if a patient has one of these, we wouldn't take it as a patient. Our research fellow, Dr. Mariana Chavez, it's working on this paper we submitted and hopefully it's published. And these are 14 cases where the left side of this column represent the patient at the moment of diagnosis in the imaging. The center represent after the patient was treated and before the patient went to the operating room. So the last imaging before going to transplant. And the third column represent the explant. And we have never had a total explant in these patients, right? This is the first time that we're doing that. And interestingly, close to 60% of the patients who have complete radiographic response of some of the metastases, including PET scan, demonstrated residual gross disease on explant pathology. I think that's it. We know that the patients have high recurrence even when we do resection, especially those ones who have disappearing liver metastases. But this is clearly showing that is not recurrence. I will call it residual disease that is there. In our activity at Rochester, we have 138 referrals. That sounds like a very big number, but if you see, only 11 patients have reached transplantation. Tomorrow we're doing another one. There are 7, perhaps not 7, maybe 6 or 5 that are still in the process for the end of this year or beginning of next year. Hopefully we can help them. Majority of them, they are not candidates because of presence of extrahepatic disease. And many patients were potential candidates but developed progression during the follow-up of these patients. Few of them were resectable when we get opinion from our center, from our surgeons, and few went for other opinions. This is the map of some of the patients that has come to Rochester to be seen. These are 30 states, and majority of the patients, we see them on telemedicine. In this paper, we kind of summarize the 2 types of patients. This is what they see normally in Norway. You know, the patient who has synchronous disease, it goes for chemotherapy. Then the patient is responding. We stop chemotherapy. We go and remove the primary tumor. Then the patient receives more chemotherapy. Hopefully the patient do not progress. There's some things that we can do here. And with Dr. Baker, we have been talking about, you know, kind of a shower of Y90. We think that the patient is going to progress to protect that liver for avoid progression, more chemotherapy, and then the liver transplant. But what we also see very commonly in the US is this type of patients with a pump, with surgeries, with local regional therapies, prolonged chemotherapy. So this is another type of patients that are going to have more damage in the liver and a higher complication rate. These are those categories that I would say. The unresectable, stable with 1 year of treatment, the burnout liver that I call it after multiple treatments, and resected and then ablation with recurrence that fulfill the criteria of unresectable. And those ones which I think I put some question marks here, those ones who are converted, unresectable converted to resectable, that I personally think that transplantation could be the best option for them. We open a trial. This is our survival on Rochester and our disease-free survival, which looks, I think, it's only 3 years because we don't have more than that follow-up. So I want to be cautious. I'm expecting to see the recurrence-free survival line coming down, but hopefully not. But I think we're very cautious in the selection. I think some tips and tricks that I always mention, I think the timing for colon resection is very important. We have decided when the patient comes for first time at 6 months after treatment, those patients who have enlarged lymph nodes in the retroperitoneum, most likely they won't be patients who will go for transplant. We do endoscopic ultrasound with 5 needle aspirations, percutaneous biopsies, laparotomies, and even laparoscopy to be sure that they don't have disease when when they're unsuspicious. When they're suspicious and the patient is coming from outside with a donor, and we start the recipient before starting the donor to avoid opening the donor. When there are long nodules, without thinking that they are cancer, we review in tumor board multiple images, including PET scan, and we have a dedicated team of Hepatobiliary team, which are our hepatologists that are learning a lot of oncology, and our oncologists that are learning a lot of hepatologies. The transplant, the pump works very well with patients for cancer, but it's very difficult to operate these patients. It creates a lot of damage in the artery. You need to use a conduit majority of the time, or mobilize your splenic artery. The portohepatitis gives chronic inflammation, and there's a lot of biliary damage. So probably not the ideal to start cases with that. We're working, and we have a biorepository, and we're working with immune cytometry, genomics, collecting this data and these tissues in conjunction with Cleveland Clinic, and also doing some quantitative stromal analysis of these tumors and the liver. So to conclude, resection and transplantation, so surgery is the goal in metastatic colorectal cancer to the liver. There are favorable results with chemotherapy that had allowed us to move and be more aggressive. Patients should have the option involving liver transplantation, and should be nowadays part of the surgeon toolbox. And clearly the multidisciplinary team approach is necessary, and we should continue moving forward. And I will stop here.
Thank you, Roberto. I hope that I'm sharing my screen now. Thank you for that really impressive talk. Every time I hear you talk, I'm just so awed by what you've done, and so excited for the patients who come forward who suddenly have a new treatment paradigm, which is exactly what we want to be doing as transplant surgeons. I was going to talk, and in the interest of time, to go through these slides relatively quickly about liver transplant for cholangiocarcinoma and really where we are and where we're going. As you know, cholangiocarcinoma is the second most common hepatic primary malignancy, and its incidence is rising. It's categorized according to anatomic location. Cholangiocarcinoma is either hilar, i.e. a Klatskin tumor traditionally, perihilar, or intrahepatic. Surgical excision to negative oncological margins really remains the most widely accepted curative intent treatment. But despite only modest improvements during the past decade, survival after resection remains only 40% at 5 years, even in margin negative resection, which is achieved only in about 30 to 80% of patients with hilar cholangiocarcinoma. So as a surgeon, relatively humbling that although this is technically feasible, the outcomes just aren't acceptable. Moreover, because these tumors are large or occur in the context of underlying liver disease, surgical resection is not always an option. And in this scenario, most patients are offered systemic chemotherapy or local regional therapy, which remains palliative, with a median survival approaching 6 to 12 months. Liver transplant is an accepted approach for patients with hilar cholangiocarcinoma who were previously deemed unresectable. Although historically, initial data showed poor survival with liver transplant alone, neoadjuvant chemoradiation therapy with liver transplant showed great promise and really became the basis for the Mayo protocol that became the standard of care for selecting and managing patients with hilar cholangiocarcinoma for liver transplant for at least the last 2 decades. The Mayo group really demonstrated there were superior results of liver transplant over resection following neoadjuvant chemoradiation, and this has become what we consider the standard of care. But it's become clear as we move forward that the restrictive patient selection and standardized Mayo protocol necessitated really further research into whether neoadjuvant chemoradiation, its individual components, and liver transplant could be validated in a broader population of patients with hilar cholangiocarcinoma. More importantly, the role of liver transplant and neoadjuvant downstaging strategies in these patients with hilar, perihilar, and intrahepatic cholangiocarcinoma needed to be explored, with each anatomic biologic variant being considered separately. I really think that the emerging world experience with liver transplant for cholangiocarcinoma is becoming quite robust, shedding hope on this orphan disease with traditionally dismal outcomes. In terms of patient selection for liver transplant for hilar cholangiocarcinoma, since its very inception, the Mayo protocol showed that there was significant debate on how far we can safely push the boundaries of patient selection towards liver transplant. It's interesting that a recent international meta-analysis by Cambridge et al., which had 20 studies and 400 total patients undergoing liver transplant for unresectable hilar cholangiocarcinoma, their pooled 5-year survival was 65% with neoadjuvant therapy versus 31% if the patients proceeded directly to liver transplant, clearly underlining the importance of the neoadjuvant therapy. Furthermore, when you look at this study by Ito et al., which was a single center North American retrospective analysis, including 59 patients with cholangiocarcinoma receiving liver transplant, the impact of ERA, tumor size, and neoadjuvant therapy, again, in each of the different subtypes were studied. And in comparison with the old data, the recent ERA, which came up to from 2008 to 2009, had significantly superior trend in overall survival rates, which again can largely be attributed to combined neoadjuvant therapy and local regional therapy for both hilar and intrahepatic cholangiocarcinoma prior to liver transplant. The 5-year overall survivals are becoming more acceptable and certainly were superior with neoadjuvant therapy before transplant compared with patients who received no therapy prior to liver transplant. So neoadjuvant chemotherapy or local therapy alone doesn't show benefit in these patients in overall survival compared to those who had no NAT, only the combination. And in addition, tumor site had no impact on overall survival, although multifocality was an important negative prognostic factor for patients with intrahepatic cholangiocarcinoma in this study. Again, really realigning what our thoughts are about how we approach patients with these orphan diseases. This study was an important study because in resectable intrahepatic cholangiocarcinoma, in a retrospective cohort of a large series of patients, again demonstrated the importance of neoadjuvant therapy plus surgery rather than surgery alone, where the overall survival went from 37% with neoadjuvant therapy to only 29% with surgery alone. Still not terrific, but certainly better with neoadjuvant therapy. In this study, which is a very important one, Sapochian and al. Really showed that in very early intrahepatic cholangiocarcinoma, single tumors less than 2 centimeters, as opposed to advanced intrahepatic cholangiocarcinoma, or what we now call locally advanced intrahepatic cholangiocarcinomas, which are single tumors greater than 2 centimeters or even multiple tumors. It showed that in the very early intrahepatic cholangiocarcinomas, outcomes are actually excellent, whether you give adjuvant therapy or not. But in the advanced intrahepatic cholangiocarcinoma, in this study, most of whom were diagnosed incidentally, not only was the patient's survival poor, but the cumulative risk of recurrence among these patients was significantly higher than those with the very early intrahepatic cholangiocarcinomas. So all of these historic data really told us that liver transplant for locally advanced intrahepatic cholangiocarcinoma should be considered a relative contraindication with limited added benefits. The Houston group, though, published this series, which really argued against this and has really catapulted the area of intrahepatic cholangiocarcinoma forward in the liver transplant arena. Carrie Lunsford and her group demonstrated an 83% 5-year overall survival with 50% recurrence-free survival in 6 patients with locally advanced intrahepatic cholangiocarcinoma who underwent liver transplant after receiving neoadjuvant therapy. Their study was extended in the next several years in the same institution to include 65 patients who were evaluated for liver transplant. Only 37% went through to transplant, demonstrating the importance of biology of disease. 18 were transplanted and 14 did not get transplant because they progressed. But the data showed that in those who were transplanted, the outcomes were really acceptable over a 5-year survival. And likely in those who didn't get transplanted, they were the ones whose biology demonstrated that they likely would never have benefited from transplant. So I really think this is an important question that we have to face today. Liver transplant for intrahepatic cholangiocarcinoma, is it ready for prime time? And I think the Methodist group really showed us that it is, and it is something that we have to consider. There are multiple ongoing clinical trials of liver transplant for cholangiocarcinoma. And I think one of the most important things about these trials is that we have to understand that this type of clinical paradigm should only be done in the setting of a clinical trial. And this was emphasized by these consensus statements that were made by the ILTS for liver transplant for cholangiocarcinoma and mixed lesions. The only consensus statement that they were willing to come up with was that liver transplant for peripheral or perihilar cholangiocarcinoma should be considered in patients with unresectable disease after neoadjuvant chemoradiation in centers with specific protocols like the Mayo Protocol. Again, really important to know that all of what we do today in liver transplant oncology has to be done in a diligent, studied manner. So I think this is a question that we all have to ask ourselves as we look at liver transplant for both cholangiocarcinoma and colorectal mets. Where do we draw the line? There's still in cholangiocarcinoma many uncertainties which we have to explore in the evolving role of liver transplant for cholangiocarcinoma. Certainly, we have to respect and understand the different subtypes of the disease, the differences between hilar, perihilar, and certainly locally advanced intrahepatic cholangiocarcinoma, each of which really has a unique biology. We have to know the benefit and the borderline resectable. I think this is the next data point that we're really going to be looking at over the next several years. We have to understand what is the impact of the underlying liver disease and whether they have PSC, whether they have no underlying liver disease, and how will this impact their overall survival. We have to consider nodal status, and in the Asian studies, nodal status is not a relative, nodal positivity is not a relative contraindication, and should we be moving more towards that kind of paradigm? We also have to understand what optimal systemic options, including immunotherapy, and certainly the advent of the TOPAZ trial, which has now become approved and standard of care, has shown us that just in 6 months, our approach to this disease has changed completely. We have to understand what the time interval from treatment and definition of biology disease to transplant is, and we can only do this in the setting of living donation when we can carefully plan these transplants around what we understand to be biological activity. And certainly we have to understand how we're going to balance immunosuppression and adjuvant chemotherapy post-transplant. I think that the role of cell-free DNA monitoring and circulating tumor cells is something that's going to really inform how we do this. And I think studies are currently being developed to really look at this in a monitored way. Very quickly, Dr. Hernandez is going to give us some case studies, but I just wanted to show you an example of what we can do when we look at these disease processes from a multidisciplinary fashion. So this was a 67-year-old African-American female who came to us with NASH cirrhosis. She had significant thrombocytopenia and a borderline high hepatic venous portal gradient. Her biopsy showed moderately differentiated intrahepatic cholangiocarcinoma, and she had no evidence on PET scan of extrahepatic disease. As you can see, this is a very large borderline resectable lesion with significant PET avidity. So at University of Chicago and now here at University of Utah, we are undergoing a very diligent downstaging multidisciplinary approach where we give staged chemotherapy, and we have shifted over to TOPAZ now that that is the standard of care for this disease. We then do intent to treat local regional therapy more chemotherapy, recovery, and then evaluation for either surgery or liver transplant. Since living donation is so important in this, we often will work up a living donor during the course of this treatment guideline. And then importantly, after liver transplant or surgery, we infer from the BILCAP studies that all of these patients should receive neoadjuvant CAPE for at least 6 months at 3 months post-transplant. So in this example, this patient received TOPAZ, received intent to treat local regional therapy with tear to her segment 4 and segment 5/8 arteries. 3 months post her treatment, she had significant response to treatment with a PET, which now showed absolutely no PET avidity. And I think amongst all of the surgeons on the call, we could really argue the treatment options, which are destination therapy, resection, or I would really like to propose that transplant would be the best way to offer this person potential overall survival improvements and overall quality of life improvements. So in conclusion, I think a multidisciplinary approach with multimodal local regional therapy is an imperative component of evaluation for liver transplant for all variants of cholangiocarcinoma, not just hilar cholangiocarcinoma. I think we really have to consider this type of treatment algorithm early at the time of diagnosis, because then it has the potential to promote acceptable survival rates, even with large and multifocal tumors whose biology will tell us what they need to do. These approaches should be considered in the context of specific protocols to allow results to inform future studies that explore optimal selection criteria for liver transplant in the context of all anatomic variants of CCA. And I think we as surgeons always have to remember, and as transplant providers, that really what we do is informed always by the biology of the tumor that is presented to us. So with that, I'd like to turn over the screen to Dr. Hernandez again to share some case studies. And again, I'm just grateful to be able to present to this group and excited to see the tumor board that will follow.
Thank you, Talia. This is pretty impressive, all those results that you're sharing. And I'm sure there's going to be a lot of people trying to develop this. And I think we need to be very cautious on collecting the data there. So I'm going to share a case. I have two, but I will go one, and maybe, Talia, if you want to present another one. So we have time to present something in both areas of cholangiocarcinoma and colorectal metastasis. So this is a patient who's 54 years old, who had a sigmoid mass. It was diagnosed with a colonoscopy as a tumor, an adenocarcinoma. There were some genetics in the biopsy that showed that this patient is wild type, so no mutations on KRAS and BRAF. No evidence of extrahepatic disease in the workup of the CT scan, and MRI was done, and also a PET scan. I don't necessarily think that a PET scan is a tool that we should be doing to initiate the workup of the patients. But in this case, this patient was outside our area, and he was done with a PET scan. CEA at the moment of the diagnosis was 280. And this is the CT scan that the patient opened with us when it was diagnosed. As you can see, there are many liver metastases. The vast majority of the metastases are located into the right side. The dome, segment 7, segment 8 are a lot. And we can see here more in the bottom, one that is larger than 5 centimeters, multiple metastases. And in the left side, you can see 1, 2, 3, 4 here. So it's bilobar disease, this patient. So the plan was, what are we going to do with these patients? The patient, so in any case, the treatment should be starting chemotherapy, systemic chemotherapy for at least 12 months, we say, when the patient talked to us. And we propose it, if you're responding after 6 months, we should consider removing the primary tumor with a minimal invasive left colectomy. If there are potential live donors, we explain the process of this patient. Otherwise, there's no reason of removing the colon if there's no potential option of transplantation. The patient responded very well. As you can see, the antigen decreased from 280 to 5. And the metastasis responded very well in imaging that I will show you. And the patient also requested, these patients requested second and third opinions. They wanted to learn about the hepatic artery pump and ablation and resection as a first approach. And this is the response that this patient had. So you can see the prime and that large lesion that was like 5 centimeters now is probably 3.5 centimeters. And maybe in this cut here, it might be around 4 centimeters or more. And you can, a small lesion here in the left lateral segment that you can see, and another one here in the bottom part of the left side of the liver. So the patient was offered, well, we should do a resection probably in the right side and trying to ablate in the left side. What we did is we did a robotic left colectomy in this patient. There was no progression of the liver disease. The patient started chemotherapy because the CA went up. Remember, it was in 5, and CA went to 10.6. What happened during this period of time that the patient is off chemotherapy? Because they need to be at least 4 weeks off chemotherapy for going for the colon surgery. And then it's going to take around other 4 weeks for the patient at least to restart chemotherapy. So we're talking about between 8 to 10 weeks with no chemotherapy. Of course, if the patient do not respond, that's a very good sign. If the patient responds and goes extrahepatic, we know that the patient is going to lose her opportunity of being transplanted. But if the patient progresses a little bit in the liver and it stays intrahepatic, then we hit it again and they go again with chemotherapy. They go for another 6 months. While in that moment, we're doing the donor workup, it's completed, and living donor liver transplant took place in that patient. And this is the donor donated all the right side of the liver. This is segment 4 and segment 2 and 3. This is the catheter that goes to the cystic duct for cholangiogram, and the donor did very well. This is the type of reconstruction that we do. We use a cadaveric graft, especially vein, reconstructing the vast majority of the time B5 and B8. And we do a common quilt with the right hepatic vein for anastomosis in the IVC. And with this, we decrease the congestion and ischemia of the anterior segment of the liver. And you can see there's a pretty good perfusion of this graft here. And interestingly, this is some pictures of the explant. As you can see, we could only see 1 or 2 little metastases in the left side and the big metastasis in the right side. And look at this patient in front has 1, 2, 3, 4, 5, 6, 7, and multiple here in the right side that couldn't see. And this was macroscopic disease. And then there was a positive cancer in the pathology. So a lot of these patients, we cannot see the tumors when they disappear. 17 months post-transplant, there's no evidence of any recurrence. The patient developed at the beginning anastomosis, developed stenosis of the bile duct, and ERCP and plastic stent was placed. The patient currently is only with 2 immunosuppressants in low dose, no evidence of recurrence, and a very good quality of life. And I will stop there. And not sure if there could be questions, Talia, or you want to present your case and then we open for questions. I'm happy anyway.
No, I'd be happy for you to go on, actually. I think this is great. In the interest of time, can I ask a quick question?
Sure.
How important do you think the genetics are, the BRAF and the KRAS mutations?
Definitely BRAF, it's extremely important. I think there has been probably 2 or 3 transplants with BRAF with not very good outcomes. I know that there's one that was very good outcome. But I think the BRAF, the B600 is the one who is the most affected. But normally these patients, they don't respond to chemotherapy very well and they progress. So these patients, a lot of them declare by themselves. So if I have a patient who has a BRAF and could be a candidate, or I have a patient who have 2 mutations such as TP53 and KRAS mutation, what I do instead of observing them for 1 year, I go beyond. And normally these patients is gonna declare by themselves that they're gonna progress. But if they don't progress, then I might consider it. And that has happened with the KRAS and TP53 mutations. So I think a lot of this data is coming from MD Anderson. Dr. Botte has done a lot of this research, but I believe more in the phenotype more than the genotype. And if I will say genotype is more looking at the patient, how they respond to chemotherapy, looking at the CEA, looking at the radiographic response, and the time. The time is going to be one of our best markers to decision making.
I think that's great. I wanted to share one of the questions in the chat also from a transplant HPB at Beaumont Royal Oak. Does the sidedness of a primary have any influence?
No. And my answer is based on the Norway data. So the presence of lymph nodes in the primary, the presence of the tumor size in the primary is not associated with the outcome or recurrence of the patient. And the criteria that it was reduced in this paper that I showed that to 1 year instead of 2 years. The follow-up, it was the marker who has less worst outcome in the patient. So they go from diagnosis to 1 year for transplantation.
Yeah, I think it just shows that we have a lot to learn.
Yes.
Dr. Rodriguez had asked that you re-show the explant findings, the prior slide, if you wouldn't mind.
This one?
Yeah.
Yeah. Sorry, I didn't know, Robert, there was the actual, like how many lesions on pathology, because I think you mentioned very important that on your explants, you have found that there's always live tumor, right? Even if the PET's negative, and that happened, you know, the case that we did with Talia recently, and you know, how to reclassify, or how do we know the you know, the chances of recurrence, and how to talk with the patient afterwards, right? I think our case study had 2 lesions residual. The one largest was probably 3 centimeters and with a lot of necrosis. So again, do we go back to the Oslo with the phone? So I didn't know if from this explant, did you know how many lesions were viable and the degree of response to the chemo?
Yeah, we always try to see response to the chemo on these patients. On those 14 cases that we have, some of them are from Cleveland. We don't have all the data from those, Manuel, but the vast majority of our patients, we have response, a good response. And actually there were, in this study, 3 patients who have hepatic artery infusion, and they have complete response, these 3 patients, with the pump. Of course, you can imagine the outcome, it was a little bit more complex. But definitely, in the vast majority of the patients, a lot of disease that you could not see in the imaging, including PET scan, they were active disease with gross pathology in the liver. So I think this explains very clear why when we do resections, there's a high recurrence, right?
Roberto, can I ask for a question for the transplant surgeons on the call? One of the things that was brought up, I believe as it was at the IHPBA by the Toronto group, was the real troubles that if you want to do a living donor, you get into with the hepatic artery infusion pumps. Can you address that at all?
Well, it could be very bad because, you know, there's to my understanding, when they place the hepatic artery pump, and probably someone here knows that, there's a lot of dissection of the porta hepatis, so they remove all the lymph nodes. Sometimes they do some resections and ablation. I don't think that will create a little bit more difficult, the surgery, but what is problematic, and you know that, is that you need to have pristine vessels for doing live donor liver transplantation. You have very short vessels and very small vessels from your donor. You know, the right hepatic artery we're using, it cannot be very long. It's short. It could be a good size, but it's small. And your portal vein could be good, but your bile duct also will be affected the majority of the time in the hepatic artery infusion pump of these patients. So the reconstruction is going to be much more complex. And what we have done is dissection of the splenic artery to match the size, and then dissect it all the way behind the pancreas and then flip it unfortunately, you can have some pancreatitis in these patients, and probably you don't want that after doing some vascular anastomosis. But at the end, things can go well, and then also you can be prepared for using a arterial conduit from your aorta and using an iliac vessel, or some people can use some cadaveric vessels as well from there. But that's what we have been doing. And the other groups that has been doing some hepatic artery infusion transplant after hepatic artery infusion, it's a similar experience.
Yeah, no, that's terrific. Well, I want to be respectful of everybody's time because I think we've already gone over, but I also wanted to, first of all, thank the ALF and thank Dr. Hernandez for doing this webinar with me. I think this is a really exciting area. I just wanted to see if there were any questions from the group that we could address just in these last few minutes, and otherwise thank everybody for participating. I know in the group there's a discussion about mTORs, and the question, I guess, Roberto, would be, when do you guys start your mTORs?
I think we try to modify them around 2 months. And I think Katie Docus was in our chat.
Yeah, she just put 6 to 12 weeks.
Right. The problem is sometimes if you have a problem with the hepatic artery, or you have a problem with your bile duct, so then this is going to delay. So we wish we could have everything as beautiful as our protocol, but probably only 50% of the patient will be as beautiful as the protocol.
Right.
No, that's.
And I think that's the importance, Roberto, of having what you're suggesting, registries and really dedicated studies to looking at this, and all of us going forward with caution, because the worst thing that we can do as a transplant community is just go forward and do these transplants and not really think about who are the right patients to include in our studies, because that's where we're going to go off piste, and perhaps the community may become unhappy with how we're moving forward. And this is an amazing opportunity for these patients who really have no other choices. I think the cholangiocarcinoma community is one where it's such an orphan disease. There really are no choices. 40% 5-year survival is just terrible for these patients, and resection outcomes are 40% at a year often. So I personally think that if we go forward in a really diligent way, and we all understand that we need to work together and we need to study these things, I think we're going to be able to do pretty incredible things in the next several years.
Right. And thank you. Thank you very much to Talia. Thank you very much to the Liver Foundation. This has been a great experience.
Yeah.
Well, doctors, thank you so much. You know, I love, it doesn't get any better to end, as Dr. Baker just said, that we're looking forward to many incredible things, and discussions like this are what will make those incredible things come alive, especially as we see our medical community coming together for these discussions. You know, if we were all together, this would be the point where we'd all move into the next room, have refreshments, and continue and continue our conversation. But in this Zoom world, we can all get our own refreshments after this. And but once again, you know, we do want to, on behalf of all of us at ALF and those present, to thank you very much. And just a reminder that this program will be streamed on our ALF YouTube channel, and we invite, please let your colleagues know about this and that they can follow up as well. And of course, I want to again thank our sponsor, Integra Life Sciences, for their support of this program. And we all look forward to seeing all of you hopefully with each other in the same room, or once again in our virtual world at another of our ALF programs. And so to the doctors and to all of you, we say have a good night and stay well.
Thank you.